epidemic diseases at the World Health Organization. Should we have any questions that they are well placed to answer. Seth, over to you.
So thank you, Ali, and thank you, friends in the media, for joining us here this afternoon. It's only been a week since we gave our last media briefing, and some of the people here I know were on that call, so I hope you're not getting sick and tired of hearing my voice. But we've also trying to be as transparent as we can at the Kovacs facility, and thought it was important to share this information to explain the progress we're making and to answer any questions you may have. So before I go into the detail, let me just provide a brief recap of the recent weeks. On December 18th, just over 6 weeks ago, we announced that Covax had met its 2020 funding target and secured access to nearly 2 billion doses of vaccines. 12 days ago, on January 22nd, we were able to tell you that we had signed an advanced purchase order for up to 40 million doses of vaccine from Pfizer-BioNTech, and taken steps to receive the first doses of the AstraZeneca Oxford candidate, either directly from AstraZeneca or via the Serum Institute of India. We followed those milestones by sending letters over the weekend to each of Covax participating economies, outlining what we're calling our first interim distribution forecast, or an early forecast of how many doses we expect to be able to distribute in the first weeks of our global rollout. We expect to be making more of these updates in the future as information on further supply of these and other candidates become available. The information is now published online, and you should have been sent a link with the statement that accompanies this briefing. Essentially, here's the key points. This first indicative distribution covers 240 million doses of the AstraZeneca Oxford vaccine licensed to the Serum Institute of India. It also covers 96 million doses of the same vaccine secured under an advanced purchase agreement signed directly between Gavi and AstraZeneca in December. Actually, I shouldn't say it is the same type of vaccine, but obviously manufactured in a different place. I have to say, in the interest of transparency, this number is less than the 153 million that we initially had contracted for in this first time period. This is not because our supply has been diverted elsewhere, but because there was a delay to the expected timeline for the candidate securing WHO emergency use listing, which means that some shipments will be moved into the third quarter. The document also covers an initial 1.2 million doses of the Pfizer-BioNTech vaccine. This is for the first quarter only. Because of the very low numbers of doses here compared to the AstraZeneca Oxford vaccine, as well as the complexity of the ultra cold chain equipment that is required to deploy it, we've had to use a very specific methodology for determining distribution of these first vaccines. I will let my colleague from WHO and Lidstrand to talk about this in a few minutes. I want to leave as much time for questions as possible, so I'll leave my remarks there. All I'll say by way of conclusion is to note the caveats we mark in the document before we can start shipping doses. And believe me, we're as impatient as you are to get these doses out. There are conditions that must be in place, not the least supply agreements, emergency use listing from WHO, and also obviously country readiness. But also we hope that you agree that today is a positive day as we think about this equity agenda that we've been talking about for a long now, less than 2 months since the first mass vaccination in a non-clinical setting anywhere in the world. At this point soon, we'll be able to start delivering life-saving vaccines globally, an outcome we know is essential if we're to have any chance of being able to beat this pandemic, as well as deal with the new scientific challenges, such as the new variants. Back over to you, Ali.
Thank you, Seth. And we'll move straight on to Anne. And hopefully you'll tell us a little bit more about the allocation actions that the World Health Organization have been going through to get us to this stage.
Thank you, Ali. Delighted to be here today, and it's really good to see that we're now just a few steps away for rolling out the first vaccines through this mechanism of fair allocation of Covax facility that can help us end this pandemic. So the role of WHO in consultations with member states and Act A partners, we have developed a fair allocation mechanism for the COVID-19 vaccines through the Covax facility. And it is a strategy to rapidly contain the pandemic, save lives, protect health care systems, and restore the global economies based on human rights principles of equity and epidemiologic evidence from the pandemic. So once the vaccines have proven safe and effective and are authorized to be used either through WHO EUL PQ processes or by any stringent regulatory authority, all countries should receive doses in proportion to their population size to immunize the highest priority groups, especially those most likely to die or who have severe disease. So the Covax facility is really pleased to now have been able to announce during this weekend to all Covax 190 countries a forecast of the early availability for doses. This is really, really key for all countries to be able to prepare and plan for the rollout and effective introduction of this vaccine. As Seth was saying, in the letter to all the countries, there were two pieces of information really crucial for planning. One was the indicative distribution of number of doses of AstraZeneca, pending a few caveats, of course. And this was intended to provide really interim guidance to all facility participants and offering this planning scenario to be able to do the preparations until we then have the final allocation numbers, which will come in the real first round of allocation. The indicative numbers that was given to all countries are non-binding and they may be subject to change. First of all, depending on the WHO EUL, the process has been started, but needs to be granted for the AstraZeneca vaccines. Pending these final decisions, and based on the current estimates of supply, the Covax facility now provided these indicative number of doses spanning Q1 and Q2, which is a good step. On the Pfizer vaccine, this was very important as well. Pfizer was, as you know, one of the first vaccines to be granted EUL. There was, through the Covax facility, only accessible 1.2 million doses. So very few doses in the first round to be allocated and sent in shipments in Q1 2021. This is fantastic. We can start vaccinating. It's good. It's coming in the next weeks. But the process to get us there, I'll just outline very quickly. We sent a letter to all Covax facility members in early January, and there was a massive interest. 72 submissions came in, and the submissions were reviewed by 6 regional review committees with staff from WHO, UNICEF, Gavi, and other members of the independent review committee of Gavi. And then taking into account that there was limited number of doses, 1.2, the complexity of this rollout of the vaccine that requires, as Seth was saying, ultra cold chain and many operational challenges more. It was important for us to try and maximize operational effectiveness and public health impact. So the decision was to limit the number that could access these few doses. And the review and assessment was done according to the principles of first participant readiness, and the vast majority were really assessed as being ready to roll out. Whether or not participants had already initiated vaccines, we thought it was more important for those who had not started yet to be able to access doses to protect their high priority populations. And then self-financing participants were also getting preferences here. And assessing particularly the last piece was crucial to us, and that was the highest possible public health impact, meaning assessment of the risk of healthcare worker exposure. So what we did was looking at the last 28 days of deaths, mortalities, which is an indicator showing us where the frontline healthcare workers are exposed to high transmissions and where we need to protect them. And the final supply of these doses is, of course, subjected to a number of caveats, which is the EUL process, but also preparations in countries on indemnification liability and certain requirements. But we hope and we see the start of rolling out of Covax facility vaccines very near, and we're delighted that it's actually happening now. Over to Henriette, I think.
Thank you very much, Anne. And we are very proud to be joining both Seth and Anne this morning, this afternoon, this evening, wherever you all are. The indicative distribution plan by the Covax facility is very important, and UNICEF is proud to be part of this. The release will help countries continue their preparations for vaccine distribution by providing them with the details of the type of vaccine each country will receive in the first and second quarters. This, of course, is just an initial tranche of Covax vaccines. More will follow. We will continue to work on the supply agreements to meet the needs of the Covax vaccine requirements for the first half of 2021. And we have some good news in that regard. Today, we are pleased to announce the conclusion of a long-term supply agreement with the Serum Institute of India for the COVID-19 vaccines to access 2 vaccine products through technology transfer from AstraZeneca and Novavax. UNICEF, along with our procurement partners, including PAHO, will have access to up to 1.1 billion doses of vaccines for around 100 countries for approximately $3 a dose for the low and lower middle income countries. This is a great value for Covax donors and a strong demonstration of one of the fundamental principles of Covax, that by pooling our resources, we can negotiate in bulk for the best possible deals. Sharing pricing information is also a reflection of UNICEF's commitment to transparency, which we have been demonstrating for the past 10 years by publishing all negotiated prices for a range of commodities. As these supply agreements are concluded, we will continue to make public relevant details of the agreements subject to the consent of the suppliers. And likewise, we look forward to working with the Serum Institute of India to distribute these vaccines to countries subject to the approval of the vaccine by WHO. With these indicative allocations, governments and public health experts can now initiate the steps needed for a successful initial rollout of the COVID vaccine to frontline healthcare workers, the first part of the largest vaccine procurement and supply operation ever mounted. For our part, UNICEF stands ready to fully support the rollout of the first batch of COVID-19 vaccines as the drive against this deadly virus shifts into higher gear. Our country offices will support governments as they move forward with this first wave to ensure that they are ready to receive the vaccines that require ultra-cold chain. This includes ensuring that health workers are fully trained on how to store and handle the vaccines. We must get this right. Many of these doses will go to health workers in urban areas who are at highest risk of exposure to COVID-19 infections. This work has already begun. For example, in Bosnia-Herzegovina, it's one of the countries that will be an early recipient of the Pfizer vaccine, which requires the ultra-cold chain storage. UNICEF is providing Bosnia and Herzegovina with 8 refrigerators that will be able to store vaccines in temperatures as low as minus 80 degrees Celsius. The first 2 refrigerators recently arrived and will be distributed to locations agreed with the Ministry of Civil Affairs. The rest will follow as soon as possible. Over recent months, UNICEF has also been preparing for this moment by stockpiling 500 million syringes, along with the safety boxes to dispose them. We have worked closely with airlines and other partners to make sure that all of the necessary logistical and planning arrangements are in place. And we are supporting governments and partners in developing national plans to assess their logistics. This includes helping to plan, coordinate, budget, and prepare the health facilities and the cold chain ahead of vaccine delivery. Along with WHO and Gavi, we are also advising countries to help improve their vaccine rollout plans every step of the way. Today's release of these plans represents an important next step. For the countries receiving initial tranches of vaccines, preparatory work can now pivot to implementation and delivery. For countries which have already initiated vaccine drives and those yet to begin, this information is a hopeful marker in the winding path out of the pandemic that will not truly be over until it is over for us all. Thank you, and back to you, Ollie.
Thanks so much, Henrietta, and tremendous news about the long-term agreement. I believe that's breaking news. That's really exciting. Frederick, before we go to questions, we're already seeing the benefits of the world's largest portfolio of vaccine candidates. But please give us some more insights into the work that's going on at CEPI.
Thank you, Ollie. And now let me join my distinguished panelists saying that today really marks a critical moment for Kovacs. And now governments around the world can start preparing to roll out COVID-19 vaccines to their populations. And with these allocations announced today, we are on the path to really start balancing out a global map, which so far has shown, how many lower income countries are yet to start vaccinating a single person, while other wealthier countries flow ahead towards mass vaccination. So, as Henrietta Fore said, we need to remember that, we are really at a critical moment in this response because as new variants of COVID-19 emerge, it's more vital than ever that we collaborate so that vaccines get both developed and made available globally. And I think this is both a humanitarian, an ethical, epidemiological, and economic imperative to get this virus under control everywhere. Because if we fail to do that and allow it to be tackled only by a few countries or on a country-by-country basis, we will not be able to escape a continued perpetual cycle of illness and lockdowns. And CEPI is, of course, a research and development support organization, and science has risen to the challenge, and it's historical that we now have multiple vaccines authorized and in use already. And Kovacs has built building on the CEPI portfolio, but also beyond that, a diverse portfolio of vaccine candidates so that we can protect populations around the world and in all kinds of settings. Now, hundreds of millions of the doses to be distributed through Covax will be the AstraZeneca Oxford vaccine, which is well suited for such a global distribution. And we're very happy that CEPI's long-standing collaboration with the University of Oxford around the underlying vaccine technology for emerging infectious diseases more broadly, together with a specific investment in R&D for this particular vaccine and in manufacturing capacity, has helped to accelerate that vaccine through development and speed up availability at scale and through Covax. But we certainly still have a long way to go. So it's pertinent to remind that continued investment in research and development is going to be critical to meet those challenges that we're facing on new variants. And we cannot afford to lose sight of the fact that this pandemic cannot be ended unless safe and effective vaccines are made available to all. Thank you.
Thank you so much, Frederick. Right, let's move on to the questions. In the interest of complete transparency, I need to take The first raised hands I can see on my screen. We'll take 3 at a time. One question per question poser, please. And also I would ask our panelists, so that we can cover as much ground as possible, to please try to keep their remarks relatively short. So first of all, we'll go to Jamie, Simon Ateba, and Christoph from AFP. Over to you, Jamie. Please let us know where you're from, and put yourself back on mute after you've spoken, please.
Hi, Oliver. Can you hear me?
Very well, thank you.
Thank you. Thank you for taking my question. I just wanted to ask Dr. Berkeley if we could get a little bit more. There's been concerns about transparency, and I was hoping that you could give us a little bit more visibility about what the pricing situation is for these vaccines that are going to be rolling out. I know that it's a bit of an issue, but it's really something that we'd like to hear as best possible in terms of the cost per unit of each of the vaccines, particularly the Pfizer vaccine. Thank you.
Thanks, Jim. We'll come to that. I mean, I can tell you that the time-honored practice is that all pricing is published in the long-term agreements that Henriette just spoke about, but I'm sure Seth will have a comment as well. Christoph, Simon Ateba from Today News Africa. What's your question?
Okay, thank you for taking my question. This is Simon Ateba from Today News Africa in Washington. South Africa announced on Monday that he had received 1 million doses of AstraZeneca vaccine from India. Can you confirm that that was under the Kovacs arrangement? And can you give us a breakdown of how the Kovacs vaccine will be distributed across Africa? And maybe finally, for the Pfizer-BioNTech vaccine, how many refrigerators are being made available to the continent of Africa? Thank you.
Thanks, Simon. A lot of the information you just requested is online. I believe in the chat, my colleagues have put the distribution document link there, so you can see about the breadth of our distribution across Africa. But we'll try to get you some comments on South Africa as well as ultra cold chain rollout. Very, very important question. And let's just move to yourself, Christoph from AFP. We'll take that question as well, please.
Hi there. Can you hear me?
Very well, thank you.
Yeah, thank you for taking my question. It's actually a clarification for Henrietta Fore. I'm not sure I understand where those 1.1 billion doses that you negotiated with the Serum Institute of India are coming from, and where will they go? Are they part of Covax? Should we add them to the total number of Covax doses that we have been talking about, which was, I think, 2 billion until the end of the year? If you could clarify that, that would be very helpful. Thank you.
Thank you, Christoph. There are a complex set of procedures involved in procurement and delivery of vaccines. And Henrietta, maybe we could start with that question, and perhaps you could explain.
So thank you. So we have a goal of 2 billion vaccines in 2021. What we've just signed with the Serum Institute of India is a long-term agreement for 1.1 billion. So it will be stretched out over a number of years. The exact numbers, as Ollie said, we will put onto the website as soon as we know them. Let me see if, Gian, if you want to add in anything.
Thanks very much, Henrietta. So yeah, very briefly, as was stated, the 1.1 billion is really, in essence, a combination of what Gavi has secured under the committed doses, the 200 million doses, plus options on a further 900 million doses. And so all of those are contracted by us. We as UNICEF, really are working to translate the advanced purchase arrangements into delivery schedules that can be transitioned to countries. So in essence, they are one of the same. They are part of the overall target of Covax, and we are effectively operationalizing the advanced purchase arrangements. Thanks.
And also responding to Simon about the doses coming to South Africa. Currently are not the ones coming out from the Covax facility. I think this is in press. We've seen more of an arrangement with the Serum Institute of AstraZeneca, I think. The doses that comes out first will be delivered with all the when all the necessary indemnification liability and the procurements and everything is done through UNICEF and coming out hopefully by the end of February, beginning of March. So that's the first rollout, and probably the AstraZeneca doses and Pfizer will be coming at the same time. For the Pfizer doses, it's South Africa, Cape Verde, and Rwanda who are among the first ones to receive the Pfizer vaccine. Over.
Thanks, Anne. Henrietta, I know you have to leave. I'm wondering, before we turn to Seth, on Jamie's question around pricing, we could just maybe have a one word from you, or a very short number of words from you. You mentioned during your remarks about the usual practice of publishing pricing on long-term agreements.
Right. So this is a very transparent process, and $3 is a good price for the world, and we are really pleased with that. So as we have each vaccine coming out and each agreement, we will be posting them. So watch that space. Thank you, Ollie.
Thanks so much, and thank you for joining us, Henrietta. We're very happy that Jan is staying with us. Seth, there's a couple of questions. Maybe if you want to add any comments regarding transparency around pricing. Also, perhaps if you could talk a little bit about the efforts being undertaken to ensure ultra cold chain infrastructure is available where needed in Gavi and Kovacs supported countries.
So thank you, Ali. In terms of pricing, I think you've already heard that this will be published in due course. There are different price points, even for different vaccines, or for different production of the same vaccine. So I think that's important, as depending upon the manufacturer, they may even divide the cost into which facilities fixed costs are being included into that. So that's why it's somewhat complex. In terms of the cold chain issues, the Pfizer BioNTech vaccine has to be transported in ultra cold chain, and so it goes in a carrier that uses dry ice as its transport media. That can be used also as part of implementation. So there needs to be a bespoke plan in each country to ask the question, can you use that carrier? Do you have the ability to produce dry ice? Do you have ultra cold chain fridges? And if not, do we need to purchase some? So we are providing financial assistance for AMC countries for ultra cold chain and cold chain as necessary. And that's part of the preparations that Anne talked about and Henrietta talked about, the bespoke plans in each country to be able to do that. Over.
Thanks so much. Okay, let's go to the next three questions. Carmen, Kai, and Jan Dirk Herberman. Carmen, let's start with you, please.
Yes, hi. Thank you so much. This is Carmen Pong from Politico in Arlington. I wanted to, just on the price, because I wanted to make sure there's no confusion. Do you have at least a price range for countries are paying for the AstraZeneca vaccines that are actually gonna be deployed to the countries that you're announcing today? And then just my question was on the variants. I wonder if, we've seen some efficacy results from Johnson & Johnson and from Novavax. In the case of Novavax, under 50% efficacious on the variant first identified in South Africa. I was wondering if that scrambles your efforts in any way to, equitably distribute these vaccines to countries most in need. Like, do you now have to focus on certain vaccines that work better on the South Africa variant, for example? How does that change any plans, if at all?
Great, lovely. Thanks, Carmen. Two good questions there. I think we've answered the question on pricing, but I'll let my panelists weigh in if there's anything more to add. We are being as transparent as we possibly can be. And the variants, another good question. So let's move on to Kai, please.
Yes, thanks for taking my question. So it's really about the, how Covax interfaces with the bilateral deals that have been struck. So I just want to know whether that enters into these decisions on where to allocate the vaccine, in any way, or whether you basically ignore all the other deals that some countries have struck. And particularly in the list, there are some countries like Canada in there, but the European countries, for instance, clearly decided not to take part. Is that a good move because it frees up vaccine for others and these countries already have a lot of bilateral deals? Or would it actually help if they if they somehow participated, just trying to understand what the significance is there.
Great. So that's a question regarding the whether or not bilateral deals have any impact on the allocations that you're looking at online. Thanks so much. And Jan-Dirk Herbermann, please.
Can you hear me?
Yep.
Yeah. Jan Herbermann, I write for Handelsblatt in Germany. First, on the BioNTech Pfizer vaccine, back in December, you announced that you've purchased 40 billion doses. Now you received only 1.2 million doses. So how disappointed are you? And when will you receive the remaining 39 million doses? And secondly, just to clarify, to the WHO lady, you were saying, correct me if I'm wrong, that you start the rollout end of February, early March. Is that correct?
Thanks so much. I believe you mentioned December. It was January we made the announcement with the Pfizer BioNTech vaccine, not December. Seth, let's start with you first. Perhaps we could talk a little bit about the whether or not there's been any impact of bilateral deals, and then also on the delivery schedule for the Pfizer BioNTech candidate, please.
So when we originally set up Kovacs, the purpose here was to do a number of things. One was to be the people to supply vaccines for countries that otherwise wouldn't get access. Of course, that's the most important thing. But the other side of it was to try to keep the number of bilateral deals down as much as possible. Of course, for a while that happened, but there's most recently been a lot of deals being made because people with the new variants and seeing doses have been quite concerned. And the last thing that was important was we saw this as an insurance policy for those countries that may have only done, let's say, a bilateral deal, because you remember when we started Covax, we had no idea whether any of these vaccines or which ones were going to work. And since we had a large portfolio, if a country ended up buying a vaccine and it turned out not to work, they would then be at the back of the queue. So there were multiple different functions that Covax was trying to do. And therefore, when we set this up, we did not use having bilateral deals as an exclusion criteria. Of course, we've asked for transparency on that. Does it help when countries that have a lot of bilateral deals don't take doses as part of it? Of course it helps, because that means there are more doses available for others. We also have put up a dose sharing program where donations are to be accepted when countries have purchased more doses than they need. And that's on our website as well. And our hope is that ultimately countries will make their vaccines available if they have excess doses or even options to the Covax facility, so we can increase the speed of rollout. Let me just go on to the question on prices. I think we've already discussed most of that, but I think the important point is we will publish those prices. Our goal is to try to get the best prices possible for all participants. That includes the low income, but also the upper middle income and the high income. And therefore, as we are negotiating deals with other companies, we are not initially making those prices available until we have these long-term agreements published, as Henrietta talked about. I don't know, Ali, if you want me to answer the others or if you're going to give them to other people.
Well, let's try a few other people first. Anne, perhaps around the variants, is there anything that you can speak to, for example, the impact of variants on our allocation?
Well, first of all, I just wanted to answer to Jan about the rollout, the importance of when actually the first vaccines will come out. And I said end February. We're not beginning of March. We're not saying a set date because there are certain caveats that we really need to set and get ready before the first Pfizer vaccines can go out. And it's about the regulatory authorization in each of these countries for this vaccine. It's also indemnification and liability, which is a legal, complicated, but really, really important step to be able to ship the vaccines to the countries. And then, of course, it's just the logistics, booking, the procurement, getting Pfizer ready and aligned and having the booking of all the vaccines and etc. So I think realistically, yes, the first vaccine, it will take a few weeks. But that is also, if you look in historical use, a very, very fast rollout that we're actually seeing from first PQL to implementation in low-income countries. There's never been a speedier process than we've seen really today. And then, Jan, you also talked about the 40 million Pfizer doses. So there's no discrepancy between the 1.2 and the 40 million. The 1.2 is the initial shipment right now. And then the full deal is 40 million that will be being rolled out in future allocation across this coming year. So the total deal is 40 million. It's not a disappointment, but it's really about the access and release early of these very important doses for high priority groups. Carmen, your question is very pertinent on efficacy of the vaccines and the difference here. There are, I mean, the good news is that we have a number of already finalized clinical trials on a number of very good vaccines. I mean, we should start there and say the world has proven to be able to bring forward efficacious and safe vaccine in this speed. That's absolutely fantastic. And most of them, or all of them actually, are responding to the target product profile that we've set out to have an efficacy of at least 50%. True, we need to watch the space of the new variants of different strains and possible impact on the vaccine efficacy. The most important, though, is that we use best the vaccines we now have and get them distributed to all of the populations that need them around the world. Maybe, Seth, you want to add to that? Thank you.
I think what's important on the science changing now is that, what these vaccines were tested. It tells us there is an effect. We saw that on Novavax. We saw that on Johnson & Johnson as well. The other vaccines have not been tested. They've had in vitro testing, but not in people. So we don't know the effect on the other vaccines. But one of the things that Frederick might want to comment on, CEPI is working with all of the manufacturers now to ask the question, how might we adapt vaccines? Do we need to think about booster doses or additional antigens or other ways to work? And the most important scientific thing, we don't know how long the vaccines last for. We don't know if we need boosters, but the really important question is, if we were to add antigens, is it the one that's there today? Is it the two? Is it the Brazilian and the South African strains? Is it others? Are there consensus ones? We need a better surveillance system to be looking across the world for strains that are there. If I could just say one other thing before Frederick comments on that, and that is, Anne was very diplomatic. Of course, we would like more BioNTech vaccines in the first and second quarter. That is what we were offered given the demand and supply that was there. And so there is no, she's absolutely right, no discrepancy between the numbers and what we're ultimately wanting to do. But of course, we encourage every manufacturer to make the largest number of doses they can available early so that we can make sure that we get equitable distribution going, so that with that, we can then help control this pandemic as quickly as possible.
Thanks, Seth. Let's bring Frederick in very briefly. We've only got 5 minutes left, so I do want to cover a few more questions if I can. But Frederick, let's talk a little bit about the work you're doing to adapt to these variants.
Yeah, no, so as Seth outlines, I mean, it opens a whole new plethora of R&D questions, and we're working very closely with all the manufacturers in terms of being as ready as possible to do what's called strain variation, so small tweaks to the vaccine so that they can actually work with new strains, either the strains we already know about or strains that actually might still be appearing. And then secondly, I think this also just underlines the importance of a quick rollout, because as long as there's such an enormous amount of virus out there, these mutations will continue. So we need to get the broader rollout going, and we need to fully finance not only vaccines, but also the diagnostics and the therapeutics under the ACT Accelerator and other tools so that we can get this pandemic under control as quickly as possible.
Thanks, Frederick. Okay, so we'll go to trying to get these very quick questions in, and short responses. Gunilla, Bianca, and Peter Kenny. Gunilla.
Yes, can you hear me?
Yes. Yeah.
Thanks for taking my question. It's mainly to Dr. Berkeley. Poorer countries have the extreme heat. They have no electricity, some of them remote communities and so forth. So they will not have the necessary cold chains to transport and store the vaccines. How concerned are you that the vaccines, because of this, will be wasted? And if I may ask a very short question, AstraZeneca, their vaccines will be a big part also of the Covax. It is not proven that they are efficient or have an efficacy for people over 65 years of age. So some European countries do not recommend to give it to people over 65. How significant is this when we think about the poorer countries?
Thanks. I'm going to also ask Gian to come in on that question. Thanks so much. But let's go to Bianca next.
Hi, Ollie. Thanks a lot for taking my question. I just received the official document, so I'm trying to understand. As far as I understood, Brazil will get the AstraZeneca with 15% of doses in the first quarter and 56 available in the second quarter. So the other 39% would go only in the second semester. Please correct me if I'm wrong. And why Brazil received less doses than Indonesia, for example? There are some other countries that received more than Brazil. What's the criteria? Thanks.
Thanks, Bianca. In the interest of time, we may need to get back to you offline on this one, but I'll let my panelists respond if they have anything that they can add to that in the meantime. But let's just do one more question. So Kesavan is next. Kesavan Kadava. Kesavan, are you there?
Can you hear me?
Yes. Can you be very quick with your question, please?
Yes, of course. I'm from Georgia, so I've just checked this distribution forecast, and more than 29,000 Pfizer vaccine is for Georgia and more than 184,000 AstraZeneca. You just said that you cannot set the exact dates. Of course, we want to know when the vaccines will be shipped and what is the how we should prepare and what's the planning. Thank you so much.
Okay, thanks. Again, when it comes to country specific, it's very difficult for us. We've only literally got 1 or 2 minutes left. I'm going to ask Gian just to talk a little bit about cold chain, because I think you also had something you wanted to add to the last question around that. And Seth, if you want to join in as well. And then the question on the AstraZeneca and whether what Covax's position regarding its usage for over 65-year-olds. But Gian, let's go to you first.
Sure, thanks, Ollie. So yes, we've received, along with our partners, 21 applications for cold chain equipment this year, and we're expecting up to around 60 from countries by the end of this quarter. And of course, Gavi's made substantial funds available for that, and we're expecting that all of those will be topped up by the likes of the World Bank. Of the 21 country applications, I think 4 have been for ultra cold chain. In the case of the first wave countries, of course, they've been selected and allocated doses based on the fact that they already have, or an assessment has been done to see that they already have sufficient ultra cold chain capacity to take on the vaccines in this first wave. And of course, there are countries from across all the regions, including Africa, in that first wave. And then I think just to add, the Pfizer vaccine with all of its specificities has a slightly different international freight footprint to other vaccines. As Seth mentioned, there's the special dry ice and packaging, and Pfizer will be handling the delivery from the factory gate to the port of entry on behalf of countries, and we'll of course be monitoring that through our supply chains. But I think it's worth noting that, and of course they're also supporting on countries with readiness to ensure that those first wave countries are indeed ready to receive the vaccines. On pricing, just one quick point. So of course, as Henrietta mentioned, we've been publishing our prices for over a decade for all of the contracts we've secured for lower income countries with the consent of manufacturers. And of course, we hope to do the same for all of the Covax supply agreements that we're putting in place, again, with the consent of manufacturers. So I'll stop here, Ollie, and hand back to you. Thanks.
Thanks, Jan. That's very comprehensive. Seth, if you have if one more minute.
Yep, I'll just say two things. One is the hypothesis that Gunilla talked about, that they don't have the extreme heat and cold chain, is not true. We've put 65,000 new units of cold chain, modern cold chain, solar, et cetera, in countries over the last 5 years as an alliance. And as you heard from Guion, more is coming. And we've delivered, billions of doses of vaccines to these countries. So there are cold chains. We also, by the way, delivered minus 80-degree vaccines to DRC in a war zone for Ebola. So it is all possible. It's just an issue of being prepared and having the right equipment. On the age issue for AstraZeneca, it is true that in the first set of clinical trials, there were only a small number of elderly cases that were read out, but there was immunologic data in older populations, and more data is coming. So the EMA has actually not restricted this vaccine in terms of age based upon the entire data packages. And of course, that's a stringent regulatory authority, nor has the MHRA, another stringent regulatory authority. So we are going with those recommendations. But of course, WHO in their pre-qualification will also make some specifications on these issues. Over.
Thanks so much, Seth.
Just adding the last second on what should countries do to prepare for this now. I just put in the chat, the link to our website. There is a big amount of training, material, guidance, and how to handle these vaccines. All countries have done a national deployment and vaccination plan of how to deliver these vaccines and how to set up the support and the cold chain and the training and everything. And that can be found on the WHO Country Readiness and Delivery website.
Lovely, thanks, Anne. Time is marching on, and I know all my panelists here have appointments that are very pressing, so we do have to end it right there. Thank you all so much for joining us. Thank you, our friends in the media, for responding at such short notice. Great to see so many of you, and we only gave you a couple of hours. I promise you, we don't try to do this, but we're moving very, very fast at the moment, as you know. For those that ask questions, or wanted to ask questions rather, again, apologies, but you know where we are. We know all of you, you know us. Come to us and we'll get them answered. Thank you so much. This session is now over.
Thank you, everybody.